Okay, well, we'll get started. So again, my name is Sushma Cribbs. I'm um, associate professor in pulmonary critical care at Emory University, and I'm one of the co-chairs for the ATS COVID Critical Care Training Forum. I'm just going to start off with a quick introduction, and then we'll get going. Thank you all for joining us today. Okay, let's share my screen. Okay, so again, welcome to the ATS COVID-19 Critical Care Training Forum. The topic today is the care of critically ill COVID-19 patients, best practices from South America, Asia, and Africa. So I will be your moderator, and we have 4 excellent presenters today, which I will introduce as we go along from all over the world, as you can see. South Africa.
Dr. Friends, I don't know if you can hear me. We can't hear you, sorry.
Oh, I'm so sorry. Can you hear me now?
Yeah.
Okay. I don't know why things are getting muted. Okay, let me go back just a little bit to make sure we're all on the right page. Thank you for letting me know. So just to kind of start here, if you're not speaking, if you could just mute yourself, that would be great. Okay, I'm just gonna mute some people here. Okay, here we go. So like I said, here are all the additional sessions that have been recorded and are available on the ATS website. This is a somewhat exhaustive list. We've been doing this now for almost a year. It's hard to believe, but please feel free to go back and see these at any time. Like I said, they're available on the ATS website. And this is the link on the ATS website, which we can also put in the chat so that you can find it. We've done 29 CCTF sessions already so far. This is the CCTF team, without whom none of this would be possible. So a big thank you to all the ATS chairs, Dr. Alexander, Dr. Shah, and Dr. Call, and then to our team of trainees, and of course to the ATS staff who have really been instrumental in putting these forward. Okay, so with that, I'm going to stop sharing my screen and introduce our first speaker, who is Dr. Buss. Dr. Buss is the president of the Department of Critical Care Medicine, a full professor from the British Hospital ICU in Montevideo, Uruguay. So Dr. Buss is going to start off our session for us. So go ahead, sir.
Well, thank you very much. It's an honor for me to be here with you all. And I will start with this learning session. I will particularly focus on 4 points that are organization of the HDU and ICU, the characteristics of COVID-19 patients that we've seen so far, and physiology. Then briefly referral to clinical management perspective of the patients, and then a follow-up after ICU and hospital discharge. Well, regarding the organization that we had to address when the pandemic started, we needed to perform some reassignment of the places that we use at the moment and the circulation regarding the COVID circulation way. So we needed to, in my university hospital, we organized a whole floor of the hospital building to for the assistance of the admitted COVID-19 patients. And at the British hospital, we needed to change the way we circulated and address certain specific areas. And also we participated in organizing a whole hospital, public hospital, for the assistance of COVID-19 patients. We needed to also to be aware of the safety of health workers and to do educational and to start to manage with these equipments that provided safety for us when assisting patients. When we needed to perform and to organize some assistance protocols for the assistance of the patients. The pandemic came here after Europe, so that was an advantage for us because we had their previous experience, and so we started with this background to start to manage patients. And also we needed to change the way we communicated with patients in this isolation model of disease that is COVID-19, and also to try to increase humanizing the ICU in this disease, and also addressing the communication with the families that were outside and couldn't see the patients. Concerning some aspects of the characteristics of the COVID-19 patients, we learned a lot so far, and so we realized that the evolution of the disease was quite predictable, if we can say this, but so we can in a certain way to predict the evolution of the disease and to see where the patient is at the moment, at the particular moment. And when at the ICU, we also found a predictable evolution, so they behaved in a certain phenotype at the very beginning, and then when the time passed, the patient started to behave in another way, so concerning respiratory mechanics, oxygenation, and that depended on other things that were happening with the patients, so infection, nosocomial infections, or barotrauma, or overload of fluid, and so we started to learn the way we needed to manage these kind of patients. And concerning respiratory failure, that is the main thing that happening to the patients, we analyzed our data and we found that there were certain particular mechanisms that were going on with those patients, particularly on one hand, pneumonitis affecting gas exchange, but also a vascular effect that was going on, and physiological dead space was having an impact on the patients. And we are trying to perform research on all of these aspects to learn a little bit more the way this disease affects the patients. And this is also leading us to rethink the way we thought the previous illnesses before the pandemic, and this is leading us to think and to be a lot more reflexive on the way we thought the assistance of the patients. Concerning the management of respiratory failure, here in our country, we don't have availability of ECMO, but we treat the patients with oxygen at the very beginning, and as patients deteriorate, we increase the non-invasive oxygen support, and but also we can arrive with certain patients to a point where we need to intubate them and perform invasive mechanical ventilation. We analyze the role of recruitment maneuvers and prone positioning, and we arrive to very interesting data. And also we started to titrate PEEP in those patients that were on invasive mechanical ventilation, and we are performing it at the moment against driving pressure. And also we are for patients that are not on invasive mechanical ventilation, that are with non-invasive procedures, studying the role of awake prone positioning and the physiological effects of these methods. We also needed to handle some other organ failure, mostly on patients that were on invasive mechanical ventilation, and we needed to address agitation and delirium, hemodynamics. This is a model of real vasoplegia, and we also needed to manage the renal failure with early renal replacement therapies. We also focus on myopathy by proper nutritional support, and also with early physiotherapy. And also we needed to manage the coagulopathy with anticoagulants as well. And when we arrived to the moment of ICU discharge and hospital discharge, we are performing a strict follow-up, and we are also doing research regarding neuropsychological sequelae that we have these patients. We are focusing on swallowing rehabilitation and physical and respiratory rehabilitation as well. And that's a little bit of what I wanted to share with you all. And thank you very much for letting me be part of this activity with you.
Thank you very much, Dr. Boss. That was a very thorough and good explanation of everything. There are no questions in the chat yet, but I was thinking we could wait and ask all our questions at the end anyway. So why don't we move on to our next speaker? So our next speaker will be Dr. Pinheiro. Dr. Pinheiro is the head of the ICU at Federal University of Juiz de Fora in Brazil. He is the professor of respiratory and critical care medicine there and the chair of the critical care committee of the Brazilian Thoracic Society. So Dr. Pinheiro, you can unmute yourself and you are ready to go.
Okay, thank you very much for the opportunity to discuss and to share with you an experience from a regional hospital ICU in Brazil. I have no commercial interest related to this presentation, and we are facing now several challenges during the COVID-19 pandemic. The limited number of ICU beds, the shortage of resources for critical care, such as ventilators, personal protective equipment, and more recently here in Brazil, oxygen shortage. The lack of device to treat refractory hypoxemia. For instance, in our ICU, we don't have ECMO or the nitric oxide, and the huge number of severely ill patients that we have to treat. And sometimes, not very rarely, we have to treat these patients with a non-ICU staff, doctors, nurses, and respiratory therapists. The huge number of severely ill patients, sometimes arriving simultaneously and having to be treated by non-ICU staff, made us to develop a mechanical ventilation protocol. And I'd like to highlight in this presentation this protocol that we are carrying out in our ICU. The aim with this protocol is trying to guarantee a protective ventilation for these patients. We know that in ARDS patients, protective ventilatory strategies have been associated with lower mortality. And these strategies include a tidal volume between 6 to 8 ml per kilo by predicted body weight, a plateau pressure lower than 30 centimeters of water, and more recently, a driving pressure lower than 15. In COVID patients, sometimes they present as a typical ARDS patients, but sometimes, besides having the same level of hypoxemia, they have a different pattern that they are calling type L phenotype for these patients. Although we recognize the differences between these two patterns, we decided to apply the protective ventilation, the same protocol for every patient with COVID-19 in our ICU. In our protocol, we started the ventilation in the volume-controlled mode with an initial tidal volume of 6 ml per kilo, and we use these equations to calculate the predicted body weight. We start with a respiratory rate of 20 per minute, an inspiratory-expiratory ratio from 1 to 2 to 1 to 3, a PEEP level of 8 to 10 centimeters of water. We start with a FiO2 of 1, but we further adjust this FiO2 according to the oxygen saturation and with this trigger level. Having set these parameters, we perform the monitoring of the mechanics of the respiratory system. We apply in the ventilator an inspiratory pulse, so we can have the plateau pressure and the driving pressure, which is the difference between the plateau pressure and the PEEP. And in our protocol, our targets for these pressures are a plateau pressure lower than 30 and a driving pressure lower than 15. The PEEP level is set according to the RDS net table, the PEEP FiO2 table. And then, according to the results of the measure of the mechanic of the respiratory system, we adjust the ventilatory parameters. For example, if the plateau pressure is higher than 30 or the driving pressure is higher than 15, we reduce the tidal volume and we can go up to 4 ml per kilo for predicted body weight, and trying to keep the same minutes ventilation, we very frequently increase the respiratory rate up to 35. Of course, trying to avoid the auto PEEP, it's not a big concern in this kind of patients. And we accept hypercapnia, providing the pH is above 7.20. On the other hand, if the plateau pressure is lower than 30, or the driving pressure is lower than 15, we can accept a big higher tidal volume up to 8 ml per kilo, especially if the patient becomes distressed with the limitation of the tidal volume. The oxygenation parameters, we set them according to this table that was published in the study alveoli, the ARDSNet group, and then we move up or down through this table to trying to keep the oxygen saturation between 93% to 96%. Then after these adjustments, if we have a PF ratio lower than 150 millimeters of mercury, it is indicated the prone position. And in our protocol, we try to follow the principles that were described in the paper that proved the benefit of prone position in ARDS patients. So we keep the same protective parameters, tidal volume, plateau pressure, and driving pressure under those safety limits. And we also choose the PEEP and the FiO2 using the same PEEP FiO2 table. There are some criteria for stopping prone treatment, and we follow them. So if the PF ratio is over 150 millimeters of mercury in supine position 4 hours at the end of the prone section, we don't prone the patient again. If after proning the patients, we see a decrease in the PF ratio more than 20% relative to the ratio in supine position, we stop the prone. And of course, we stop the prone if the patient develops a respiratory or a hemodynamic instability. After the prone position, if we still have a hypoxemia that is refractory, then we have to try something else. And since we don't have ECMO or nitric oxide, we try a trial of alveolar recruitment. And then we will apply the maneuver that is described here in this slide. So we change the ventilatory mode to pressure controlled ventilation, and we set pressure of 15 above the PEEP level, and then we increase the PEEP from 10 to up to 25 centimeters of water, and each step lasts 2 minutes. After this recruitment phase, we start trying to titrate the PEEP level, the best PEEP level, and we do this decreasing the PEEP level in steps of 5 minutes, and then we go down to 10 centimeters of water. The best PEEP is achieved by the PEEP who relates to the best compliance of the respiratory system. Sometimes, if this maneuver isn't enough to achieve a good oxygenation, a PF over than at least 100, we sometimes increase the recruitment phase to 35 centimeters of water. With this protocol, we think that we are achieving good results. That's the results of our patients. Up to now, we have treated 134 patients, and they are really severe patients. We can see the proportion of them that received vasopressor, neuromuscular blockers, almost 1/3 had hemodialysis and were prone and were performed had a tracheostomy performed. Our 28-day mortality is 36%, the ICU mortality 47%, and the hospital mortality 56%. That's what I'd like to share with you, our experience applying this protocol. Thank you very much for your attention.
Thank you very much, Dr. Pinheiro. That's an excellent overview. It's very interesting to see the protocols that are happening in your countries. Okay, we will move on to our next speaker, Dr. Cho. Dr. Cho is a professor in the Division of Pulmonary and Critical Care at Seoul National University and Bundog Hospital. He's also the director of the Fellowship Training Program of Critical Care Medicine. Dr. Cho is actually working at the hospital at the moment, so thank you so much for joining us while you're on call. But you are free to go ahead and start whenever you're ready.
Okay, thank you for nice introduce for me. And I am Young Jae-jo from Seoul National University Bundang Hospital. And today I talk about the lessons from a critical care for COVID-19 in South Korea experience. This is my disclosure. This is my hospital where I work. Korea had a nationally designated quarantine bed based on the experience of MERS. So this quarantine bed was created about 4 years ago. So we were thinking about this receiving severe respiratory distress patients. So in fact, at the end of January last year, when there were confirmed COVID-19 from another area, the treatment was principle for ARDS would be fully applied at that time. So it was great help in that I was able to realize a little earlier than I wasn't afraid of illness while seeing the patient could get better. First of all, let me tell you the case of the 54 years old man with COVID-19 critical ill who was admitted to our hospital recently, actually 3 days ago. In the past, the patient who had the only history of hypertension and panic disorder was the one who operated a daycare center. And on January 31st, the patient who entered the self-isolation after being exposed to a confirmed patient for the first time and developed symptoms on February 6th, 7 days after contact, and was tested positive for SARS-CoV-2 PCR. Next day, patient was admitted to a local public hospital for oxygen therapy and drug treatment through Life Treatment Center in South Korea. But on 21st of February, 3 days ago, intubation was performed and we were transferred him to our hospital for advanced treatment of critical ill patient. The patient transportation route. The picture you see, the chest X-ray picture at the time of the severe respiratory distress and before the airway intubation. If you look at the chest CT picture, and so the picture show the very typical COVID-19 ARDS finding. And after intubation, he was transferred to our hospital. The coronavirus PCR was still positive in upper and lower tract specimen and very elevated D-dimer. CRP was detected and procalcitonin, which could be suspected of bacterial infection, was slightly elevated findings. Before looking at the patient future progress, I will tell you about the situation in my hospital and surrounding areas. The Gyeonggi-do is, which I belong to, is an administrative district surrounding Seoul. This is Seoul and around is Gyeonggi. And so the total population is slightly larger than that of Seoul. But on the other hand, it is easy to see this picture, the high-level general hospital, such as Raji Hospital or University Hospital, are relatively distributed only in the south area in Gyeonggi. And these numbers are very small compared to Seoul. Seoul is the capital and special city in South Korea. So we recognize the importance of transporting COVID-19 critical patients after the first epidemic ended and before the second epidemic began. So we assigned our hospital as a base hospital here and the local public hospital as the starting point. And we simulated a critical patient transportation that is about an hour away. And so in fact, at that time, there was no national guideline or any kind of system for the transportation of critical ill patients in South Korea. And I wonder this YouTube is playing, but I try. And so this is the real simulation. And so this is a starting point, the hospital, the regional hospital. And so this is a simulator. And so we really simulated how to transport the COVID-19 patient like this. And there is me. And so this is the ambulance and real transportation simulation. And then in the ambulance, we broadcasting in live to the ambulance person or this. And then here is my hospital and the arrived situation and some interview and the debriefing situation. So this is imaging, transportation simulation, the starting point, the hospital, and broadcast the situation inside the ambulance in real time during the actual transport process. And after receive patient and feedback, and then we enter simulation process was debriefed and training was ended. And this was the last August, the hottest season in South Korea. However, we had to prepare for a situation where the number of critical ill patients is increasing due to lack of the proper transport system immediately. So the second regional public hospital themselves have reorganizing so that they can be equipped with intensive care capability so that can newly accommodate the COVID-19 critical ill patient. As you can see this picture, the one critical care physician, this is me, and one critical care nurse were in charge of on-site training and practice. And this training was conducted for about 2 weeks, and the necessary building construction costs or various equipment were borne by the local administration organization. And since then, this hospital accommodated the critical ill patient with COVID-19 actively in Gyeonggi area. Going back to the case, the patient actually transferred here 3 days ago, right now, and from the hospital in northern area of the Gyeonggi, which is exactly about the same distance during the simulation, but opposite to the previous simulation hospital. But to be honest, it's been more than 6 months since the simulation, but hospital in my area still had not have enough ambulance to safely transport critical ill patients, whether they are COVID-19 patient or not. So this patient was also transported to my hospital in a very dangerous condition. Therefore, at the same time as the patient arrived at my hospital, the Sunday afternoon, the hypoxia could not maintain 90% of SpO2, even in full set of the ventilator with FiO2 1.0. And we began to receive inhaled nitric oxide primarily, and then hypoxia could actually be rescued. The mechanism of nitric oxide as a vasodilator, you can see in the picture, is thought to be something you know at least once previously. However, I think it seemed that the quantum medical guideline that accurately describe inhaled nitric oxide indication for COVID-19 only in NIH guideline. And looking at the actual content with the level of corresponding to the C3 recommendation and evidence. And so the statement is described like this. The panel recommends using an inhaled pulmonary vasodilator as a rescue therapy. If no rapid improvement in oxygenation is observed, treatment should be tapered up. This is the result of my inquiry on the criticaltrials.gov site yesterday, and the number of inhaled nitric oxide related clinical trials registered here is also being carried out in a handful of cases. And the actual phase 2 or 3 clinical trials are being prepared or started. So like this new machine, and not in South Korea, but in Canada or US. So I think we will pay attention to the result in the future. In fact, the situation in Korea is also unique. Currently, only newborn and children can use the foreign INO product that are approved for insurance coverage in Korea. And in most adult patients, many hospitals has only delivery equipment, but there is no medically usable gas. However, a domestic company recently said that it has completed the preparation to obtain approval from regulatory agency for INO as medical gas. And one company and another regulatory agency are also considering expanding indication. So I expect that INO can be used as a rescue therapy for COVID-19 ARDS patient in the future. Going back to the case, the patient then had this worsening ABGA outcome in afternoon on the same day, less than few hours later. So if you look at the ventilator parameter here, you can see the tidal volume drop sharply. And once the hypoxia did not get worse, but hypercapnia got worse. But I tried to prone positioning first. And as a result, it showed the ABJ result that were recovered again. I would like to show you one interesting result related to prone positioning. This slide showed a simple bipersonal survey result from various institutions. At the time, the first epidemic was just over. You can see that the rate of ECMO practice was significantly higher than the rate of prone positioning at that time. In fact, to understand this phenomenon, it is necessary to understand some unique situation in South Korea. And if you look at this slide, when you see only the country surveyed with the data requested by South American expert, I heard, and we confirmed that the percentage of ECMO equipment possession in Korea was relatively high. And so, and in addition, how about the proning and ECMOing in South Korea? When compared between the implementing proning or ECMOing, I think we can make a table as follows, especially in the last line. Regarding insurance coverage or reimbursement, prone has no compensation for its action. Instead of that of ECMO is very high. So it can be simply inferred that I think there is a very contradictory situation in South Korea that makes it difficult to implement the prone position before ECMO in the ICU. This is my personal opinion. And another example is, I mentioned earlier in the case of the regional hospital that I build up and reorganizing as ICU care, it was at least 6 months before the first successful prone positional patient there. So I think it is a prime example of the significant difference between we are knowing and doing it in real clinical field. And the third and last thing I wanted to talk about is ECMO rescue. Actually, the patient maintained oxygenation there the next morning, but the tidal volume also reduced again. So protective ventilation was no longer possible. Then I initiated the VV ECMO immediately. This is the chest X-ray and symptom abdomen immediately after ECMO application. And if you look at the ABJ result, And you can easily see the rescue was successful. And in Korea, most ECMO procedure and equipment are actually owned by cardiothoracic surgeon, not pulmonologist like me. And so recently, our Korean Society for Thoracic and Cardiovascular Surgery analyzed the cases of ECMO in 61 critical ill patients with COVID-19 in 21 hospitals and derived the following recommendation. The contents of the advisory are well organized in the table you see. You can see the first is the establishment of an ECMO management system at each individual ECMO center. So number one, multidisciplinary ECMO team, and number two, referral and retrieval system. And number two is the establishment of the criteria for patient selection and early alert criteria. And if ARDS or if cardiogenic shock, there are some criteria, blah, blah, blah. And number three, if we case surgery situation, triage and allocation is should be more strict. And so finally, number four is we can consider futility or ethical issue of life-sustaining treatment like ECMO. So this is a well-established guideline right now. But the ocean mentioned the content to be considered more deeply as follows. And the first, age issue. Unlike foreign country in Korea, many elderly patients had applied ECMO. And there should still be, we need a scoring system to know the most optimal ECMO starting point. And the Korean COVID-19 confirmed case feel like pulmonary thromboembolism occurrence are low, I think. But we also think about that there is a concern about whether this had been underestimated. And so this is what I mentioned earlier, the referral and retrieval system and the publicly safely. And some data I wanted to show briefly, but it's time to not enough for me. So this is South Korea and compared to ELSO or Euro ELSO. And the mortality rate was relatively not very high, but there are many patients still ongoing ECMO. So we will wait the final result a little more, several months later. And this is a very encouraging fact, is that survival rate is increasing over time in more and more performed patient. And so as I mentioned earlier, it is personally very encouraging that the proportion of patients receiving prone position before ECMO is increasing more and more. And 9, 10, 16, 20, 25% in February. So we are still learning through our own experience, I think. Actually, the patient clinical finding yesterday was relatively stable and all treatment well received, and the current ABJ result is very good. So overall progression is good and inflammatory marker level also decreasing. And so this is a current situation. Okay, let's take home message, summary of my presentation. And number one, transportation of critical COVID-19 in South Korea is still problematic. And number two, as a rescue therapy for COVID-19 ARDS, the rate of prone positioning increase. And our ECMO survival rate in critical COVID-19 is also increasing. And if formally commercialized, the INO can be available, I think we can try to plan a multi-center RCT in COVID-19 ARDS. And so I great thanks to my society colleague for this presentation. And we are planned to APSR will be held in South Korea next year in 2022. And so I sincerely looking for see many people in one place at that time. So thank you very much for your attention. Thank you.
Thank you, Dr. Cho. I'm amazed by how much ECMO that you all are doing. It's really impressive to see. So we don't get too late, I do want to make sure we have time for our last speaker, and then we'll get to the questions that have been posted in the chats. So Dr. Singh is our last but not least speaker. So Dr. Singh is actually a pediatric intensivist at Inkosi Albert Lutuli Central Hospital in Durban, South Africa. So Dr. Singh, you are ready to start?
Hi, good morning. Can you hear me?
Yes, we can hear you. Thank you.
Great. Thank you very much for including me on this adult panel. It's always intimidating for the pediatric people to be on this panel with the adults, but I'm very happy to share our experience of it. I come from Durban, which was previously well known for its warm tropical beaches, but now is probably more known for the elucidation of the South African variant that is now available in South Africa. So just looking in terms of the pediatric perspectives, I thought that we could just give some of the clinical presentations of pediatric cases that we have been seeing over the last year. And startingly, what some of the problematic situations maybe is there different presentation with the variants that are occurring and that we are seeing anecdotally. And the complications regarding medical therapy for infants and children, because although this has been described as a septic shock type of syndrome, it behaves very differently to septic shock. Just to give you a bit of perspective about the pediatric population in South Africa, this accounts for over 1/3 of the South African population and has accounted for about 9% of lab-confirmed COVID cases and 3.9% of hospital admissions related to pediatrics. The two main age groups that tend to be affected is the age group less than a year, and then the age group between 15 to 19 years that we are seeing, with a hospital intensive care admission rate of 6.7%. And at some time during this admission, 2.3% patients are being ventilated. So although the numbers are not as high as the adults, and as a pediatric intensivist, we're obviously seeing the very skewed end of the situation, the issue is related to the fact of whether there has been changes with regard to the new variants emerging. So with regard to the in-hospital case fatality risk, the risk runs at about 2.9%, and the majority of these deaths tend to be children between the 15 to 19 years of age. Incidentally, this age group is the age group that's actually housed in our adult intensive care units, and the pediatric units tend to go up to the age of under 15 in the pediatric units. So the first case of COVID followed the rest of the South African wave found in March 2020 last year, and that started in our province, KwaZulu-Natal. And in November last year, we started seeing the second wave. In December, the new variant of the COVID virus was detected in KwaZulu-Natal, which is the 501Y V2 variant, which is very similar to the UK variant, except that is phenotypically different. And this virus has now been replacing many of the previous strain variants of the virus. So part of the presentation that many will be familiar with is the multisystemic inflammatory syndrome in children, or PIMS as the terminology was previously, that occurs approximately 2 to 6 weeks after the COVID exposure, when children are presenting asymptomatic. And we've seen most of these presentations at about 30 days. There was publication in the Lancet from our colleagues in Cape Town who had the time in July 2020 seen one of the largest case series of systemic inflammatory syndrome in children when they were experiencing their wave to MIS-C. So I just wanted to discuss one of the cases, the first case of MIS-C that came to us. And although this is a mortality, I think it reflects quite a number of the complications related to this type of cases. So this was a 13-year-old boy who had been referred from the private sector in South Africa. And our hospital is the foremost academic tertiary unit for pediatric intensive care, with facilities that do not exist in the private sector either, and was transferred to us after a 5-day history of fever, gastrointestinal symptoms of diarrhea, vomiting, and abdominal pain, and sore throat. Incidentally, the GIT symptoms of these pediatric patients are the majority of the symptoms that are presented in terms of the MIS-C type of individuals. At the time, there was no antibody testing for COVID, but had an IgG antibody positive done in the private sector, with the PCR being negative, and no known COVID contacts, although a grandfather had been symptomatic but not tested. So this child presented with severe multi-organ dysfunction and severe refractory hypertension with a fractional shortening of 18%, requiring 5 inotropes, vasopressors, including vasopressin, had received hemodialysis at the base for the previous day in acute renal failure with tubular necrosis, bilateral interstitial ARDS, and had continuing gastroenteritis and intestinal symptoms. Many of these patients progressed to negative laparotomies for exclusion of appendicitis. This patient did not actually have a laparotomy in relation to any consideration for appendicitis, which had been excluded. So on admission, you can see that the MIS markers showed high inflammatory markers on presentation. With these markers that are available to us in our institution, what is different about these cases is that we don't usually do interleukin-6 as markers for sepsis previously in the non-COVID era, and interleukin-6 was predominantly started to being used for patients who were suspected to have this infection in the absence of PCR positive COVID. Just to give you an idea of the rash that is described, MIS-C is described as a Kawasaki or a Coronasaki type of illness with a rash and fever inflammation related with undisclosed causes. So this is the type of presentation of the rash on the darker skinned individuals that was not a common presentation. This is just to give an overview of the changes in the numbers during this child's stay in our intensive care unit, with particular reference to the fact that most of the parameters tended to improve, and this child remained in our ICU for about 36 days of ventilation, except the ferritin. And there's recently been much talk and discussion about the role of PCT, ferritin, and CRP in distinguishing between inflammation, infection related to COVID. So as I've mentioned, his progress in the ICU had shown some improvement in most of the major organ system, including the cardiovascular, with an improvement of his FS to about 40% after about 23 days of ventilation. Or ARDS had resolved, and he required then reintubation after having been extubated in the last few days of his stay in the ICU related to hospital-acquired infections and probably ICU-induced weakness with the respiratory muscle weakness that he had. The one aspect that I wanted to just discuss was the type of medication that these children have been given in terms of the MIS-C protocols that we've been using, courses of intravenous immunoglobulins, dexamethasone, and this child responded poorly to dexamethasone initially and had to be escalated to methylprednisone over a 3-day course and then a 7-day course of dexamethasone. In terms of his inflammatory markers, the steroids were ongoing in terms of titration to the inflammatory markers. Tocilizumab, or the interleukin-6 receptor antibody, is not something that is available to us in the public sector. And this particular patient had sourced it within the private sector and had been given the first few doses already, and came to us with that in hand. Anticoagulation is also another new issue for pediatric patients, and heparinization and Clexane starting by in the initial phases, and then increasing use of the anticoagulation to day 30. The liver dysfunction contributed to the GIT intolerance that this child was having in terms of TPN use, and the use of antifungals in the treatment of his sepsis, which I'll just go on to now. Part of the complications related to this child is that although much of his organ dysfunction had improved, he then started presenting with the ICU complications that may perhaps have not been COVID related. However, unusual organisms were cultured on this child, including an Obsidia, which is a necrotizing fulminant fungal infection that we have not had in our unit, including the CRE Klebsiella pneumonia, which this child subsequently grew on the swabs. Unfortunately, he demised on day 36 following a severe pulmonary hemorrhage, which again highlights the complications of treatment in this children. Just to give you an idea, these are post-mortem pictures of the child and the lesion that was basically related to the Obsidia that is involved as a necrotizing flesh-eating type of fungus, also causing quite severe necrotizing pulmonary disease as well, which may have accounted for the pulmonary hemorrhage. So the consideration in these patients, and our thoughts at that time, since the management was new, is whether the incidence of fungal infections in the COVID patients are particularly higher than your normal prolonged ICU patients. And the studies that we have done in our unit show that the incidence of fungal infections is 2.6% for invasive fungal infections, as opposed to 10 to 11% at other centers. And looking at the data for SARS in 2003, fungal infections were one of the main cause of death for patients. And the other data that look at 2020 COVID-19 infections saw also the elucidation of other odd fungi being available in those situations. So he had plenty of risk factors for the invasive mucosis, mucormycosis that we are seeing in this patient, notwithstanding the issue of diabetes and glucocorticoid use that had been extensive in him. So I'm just going to jump quickly then to the second wave cases, and these are the cases that we are now currently looking at in terms of what's happening anecdotally with what we're seeing in the difference in presentation. So we've had quite successful cases resulting in the MIS-C type of patients that have been presenting. And that patient was one of the two deaths that we had from MIS-C children, the rest having been discharged from the intensive care unit with good follow-up and good myocardial function thereafter, and very little sequelae. The second wave cases are seeing a different type of population, and these are patients related to younger population in infancy, 1 to 3 months of age. And this illustrates one of those cases. This is a 1 month, 26-day-old HIV positive baby on heart therapy during the preterm period, and had been rapid antigen and PCR positive for COVID. The clinical presentation, very short, and what characterizes this type of patient is the progressive ARDS in the subsequent days after ventilation. So initially this child had a PF ratio of 456, which rapidly deteriorated to PF ratios of about 62. Severe pulmonary hypertension as well, and clinically handling very poorly. These patients we managed in all the modalities with proning, as we do for the adults, since there is very little data for children at the moment. Proning N-acetylcysteine was used. In terms of nitric oxide, we do have access to nitric oxide. However, the resource is limited, especially for running a non-COVID ICU and patients that are cardiac and post-cardiac surgery. So the COVID unit as such, which we run concurrently with the negative ICU, does not have nitric oxide allocated to that particular unit. Given that we've gone through the analogs of milrinone and sildenafil, knowing that the success of this in pulmonary hypertension in infancy and has been quite robust in the pediatric population as well. Vasopressors were used on this patient with noradrenaline, milrinone, and again, anticoagulation is the new aspect that was added in terms of the pathophysiology that we've known from the adults. Again, treated with immunoglobulins and courses of steroids. At this point, with the progression of hypoxemia in this patient, even colchicine had been tried following the recent evidence about colchicine in adult patients. And colchicine, more than other drugs, is probably something that people are more familiar with related to Mediterranean fever and also the juvenile rheumatology patients that use colchicine as well. So as you can see on the admission bloods with this particular patient, the inflammatory markers at this point were not particularly remarkable. And just the ferritin levels that give an idea of the high inflammatory state of these individuals. The LDH, which we see in pneumonic patients in our population related either to PCP from HIV, is not uncommon. So really not a remarkable picture in terms of the inflammatory markers, but a very definite picture in terms of the type of ARDS we're seeing, and this shows the progression of the VQ mismatch that we were seeing and the issues with pulmonary hypertension that we were seeing during this time. At this point, on about day 13, this baby had to be oscillated. And I think there has been a lot of discussion about oscillation being a rapidly aerosol generating procedure in COVID ICUs. And that's a modality pediatrics are very comfortable with. However, given the concerns about aerosolization, high frequency oscillation had been lesser used in the COVID ICU. But with the type of cases that we are now encountering with ARDS, we have had to adapt the high frequency oscillation ventilators such that the aerosol generation is kept to a minimum. And part of the difficulties related to that is being the absence of filters, ventilatory filters in these patients and on the circuits that are of adequate size to avoid the dead spacing that we're finding with the circuit challenges and the filters. So again, this patient complicated with hospital-acquired infections, Klebsiella and Enterococcus, and unfortunately, we've lost this child about 2 days ago with severe septic shock and severe hypoxic ischemic encephalopathy, which is a major issue in infant children with regard to anticoagulation and intracranial hemorrhaging and the degree and sensitivity of the brain to prolonged hypoxemia, pulmonary hypertension. So I think what these cases illustrate for us is that although the pediatric perspective in South Africa has a low incidence, there is concern that with the change in the variants, there may be a change in the major presentation types that we are seeing, a multi-inflammatory syndrome type of situation versus the severe ARDS, pulmonary hypertension, which sort of fits in with the adult type of picture. And the change in presentations may be related. All of this is anecdotal because the genomic studies are largely research-based, but the present genomic studies for South Africa suggest that the variant is the major variant in the population at the moment. And the complicated course for the medical therapy for infants and children are largely extrapolated again from adults. And although we say this is very similar to sepsis, it again falls outside our comfort zone with regard to high use of steroids, prolonged use of steroids, anticoagulation in our pediatric population, and the other prolonged ICU complications that exist in just with prolonged ICU stay. So that's essentially the experience that we've been having. And again, this is an evolving situation that we've had in our institution. Thank you again for the opportunity to speak.
Thank you so much, Dr. Sang. We did have several questions that I'll get to. I'm just going to share my slides that have those so I can post those questions to all the panelists. Before we get to that, Dr. Sang, I had a question for you. I was just curious as to your thoughts on why you think with the second wave you're seeing so much younger patients. Do you think it's the variant that's just affecting the patients earlier?
Yeah, I mean, many of these patients, especially the infants, obviously have the context being the adult caregivers, the moms or the family surrounding them. We're not seeing that degree of severity within the adults. So these babies don't present with moms who are equally sick. So that's also the other conundrum in the whole thing. So unless we can actually prove that this is the genomic related variant, what we can say, or what I've been seeing for certain, is the fact that the presentation is hugely different from what we were seeing in March, April. And combined with the long distances of traveling that Professor Cho has also mentioned, I mean, our areas for traveling and getting to our institution for intensive care is also a prolonged course. And that impacts on them because they are so fragile with the severe pulmonary hypertension that anything that you do on them causes a huge de-recruitment just from suctioning or handling or procedures, despite paralysis that they are on when they are on the oscillator.
It's just so terrible to think about. Okay, so let me share my screen, and we'll just kind of start with some of the questions I've gotten from the chat. And so for our speakers, maybe you could all, whoever wants to take some of these questions and speak to your experience in your country. So the first question was, excuse me 1 second. Let me make sure okay, yes, this was our first question. What has been your experience with ivermectin, if at all? Have any of you used ivermectin in your ICUs?
In South Korea, I don't have any experience with ivermectin.
Okay. I personally don't either, so.
In South Africa, we've just received now approval for ivermectin use in adult patients. It was previously obviously just registered for animal use and had been available on the undercurrent and black market for some time for adults until it got registered. So it's now being approved for use for adult patients. So we will have to see whether it makes a difference or not.
Yeah, thank you for that. Yeah, it'd be interesting to see what the data on that shows. Our second question was, what is the recommendation to start antibiotics in COVID? So anyone that wants to respond to that. I know Dr. Bass and Dr. Cho put some comments in the chat, but maybe you can expand on that a little bit.
Well, I think it's a difficult question, and frequently when we receive these patients in the ICU, we are not sure if there is a superinfection, a bacteria simultaneously. So we use azithromycin and ceftriaxone to treat these patients at the very beginning. And then we follow them during the mechanical ventilation. And if we suspect the occurrence of ventilator-associated pneumonia, we increase the spectrum of the antibiotics according to our experience regarding the microbiology of our ICU. And unfortunately, this kind of infections very frequently in our unit.
Yeah, Sushma, just to answer from our perspective, we obviously see a high incidence of sepsis concurrently. Having said that, in the COVID patients, we are not finding bacterial cultures or that are positive on the initial admission cultures. But given the delay in getting the microbiology results back, we do start them on prophylactic antibiotics, broad spectrum antibiotics when they come in, and titrate them off if the cultures so deem.
Yeah.
Sorry, I think this is a very important question concerning the use of antibiotics. Particularly, we are very restrictive with the use of antibiotics in order to have a positive impact on the bacteria at the unit. So we monitor this very strictly, and we start antibiotics when there is a high thought that there is an ongoing nosocomial infection. But this is really a very interesting point, and so we are struggling on this, and it's very difficult to find the exact balance when to start and not to start too late with the antibiotic. So it's a good point.
Yeah, I mean, I agree completely with everything you're saying. We're also struggling with that. You know, I think using all the measures that many of you posted in the chat, you know, thinking about sputum cultures, getting tracheal aspirates, procalcitonin, white blood cell count, fevers, you know, using all your data to see if somebody qualifies for community-acquired pneumonia therapy. And then, like Dr. Pinheiro said, we're also practicing the same way, that once they get on a ventilator, if their aspirate is positive after that, then broadening based on those. But it's a difficult question trying to balance, you know, antibiotic stewardship versus your sick patient and how to take care of them at the same time. So it's a good question.
I totally agree, Dr. Cripps.
But yeah, I know, so much antibiotics. So our next question, what is your experience using anti-IL-6 or tocilizumab in the ICU? Do any of you have experience using that?
I personally don't.
Okay.
I don't.
We've just used it on that one index case that I presented. The concern is the type of immunosuppression that you're also getting with the tocilizumab.
Yeah.
In addition, with the use and the predilection thereafter for hospital-acquired infection. In fact, that was one of the discussions of whether that might have been a risk factor for the unusual organisms that we were culturing in this particular child. So again, it comes with a degree of problems as well.
Absolutely. Yeah, I personally have not used it either. At the beginning of the pandemic, we were measuring IL-6 levels in everybody, but not really using it for anything. So in general, my practice has stopped doing that as well. Okay, so our next question. Oh, go ahead. Did someone want to say something? Okay, so our next question was, are your non-critically ill COVID positive patients sharing rooms in your hospitals?
No, fortunately, we were able to arrange our hospital to keep them apart. So we have special units to treat the COVID patients, and they stay there until, if they go to the mechanical ventilation, they stay there for at least 1 day. After this period of time, we try to transfer them to the common unit, to the common ICU, and to have free beds for other patients. But during the contagious phase of the disease, we have a dedicated ICU for them.
Yes, our practice has been very similar.
I think our resources obligate the fact that patients that are requiring a high care situation are housed in the high care COVID unit, separate obviously from the non-COVID patients, and the intensive care unit functions both as a high care and intensive care unit. It's the spacing and the resource limitations of those bed spaces don't allow us the luxury of individually housing them or isolating them or separating them in any other way. I think just as an important corollary to that, part of our difficulty has been with the long stay ICU patients and the fact that the resource for these beds are limited, because we're also accepting COVID negative patients at the same time, which has not decreased in terms of admission rates. When to actually de-escalate those COVID patients into the normal or the non-COVID ICU. And I think there's very little data, especially with children, regarding the non-infectivity rate of them on the ventilator when your PR converts to being negative. We are not routinely doing cycle thresholds on these patients to determine the infectivity risk. And having them lying in the COVID ICU of a limited resource for 30 days, going over 30 days is quite an issue when the admissions keep coming in. So I just wanted to find out if anybody else has experience of de-escalation in terms of the COVID ICU patients to other areas, or are they all just being continued to be housed in your COVID units?
So for us personally, we do de-escalate after 21 days. Sometimes to be safe, we'll do 28 days, but generally 21 to 28 days after they've been from their first set of symptoms and their test. After that, then we'll move them into our non-COVID ICU. And that's how we've done it. We're not repeating testing because, as I'm sure everyone on this call knows, people can test positive for months and months to come. And so we're just using the time frame as not being infectious anymore. I don't know how that translates to children, since the data for children is so limited. So I think it's hard to know.
Well, I don't know whether anyone actually knows how that translates for adults, because a lot of the CDC guidelines are related to more mild to moderate cases, and really not the ventilated ICU patients that are being de-escalated after a time period rather than for a ventilation period. Because by definition, if they're on the ventilation, they're probably still symptomatic. And I think my concern is whether they are still symptomatic from the COVID, or whether it's another issue. And until you look at the cycle threshold,
Sure.
Able to know.
I will say that just anecdotally, we have a patient now, for example, who's been in the ICU for 30 plus days, and we haven't moved him because he still is so ill. The patients we have moved are the ones that have been either extubated or, like, clinically they've improved. So I think your question's a good point. You know, for those patients who are not improving and are continuing to stay ill, you know, how do you manage those? So. Okay, so in the interest of time, I'll keep going just to make sure we get through all our questions. One of the questions, are there studies from use of pulmonary surfactant in COVID-19 patients through flexible bronchoscopy?
No, I don't have. But very interesting, I think.
Yeah, I'm not sure myself. Do any thoughts on that?
The best of my knowledge, there are some case reports and prospective cohorts, but I haven't seen randomized clinical trials. And based on the results that we have in non-COVID ARDS patients, probably the results are not that good.
Yeah, agreed.
Mm-hmm.
So I actually was wondering if you all were seeing patients with long COVID and how you're managing those patients in your clinics, and are you seeing these patients return from a how you're managing their rehab. These questions have come up on our previous forum. So since I have you all on the call today, I thought I would get your opinion about that.
Let me share my experience about the long COVID patient. Actually, yesterday or the day after yesterday, I met my COVID patient discharged after 6 months of admission in my hospital. 2 long COVID patient, and so he had 3 months in ICU and another 3 months in non-ICU. But we are collaborating with the rehab team for COVID-19, and so one rehabilitation medicine doctor are very interested in the post-COVID-19 long-term complication, how to rehab. And so, but we don't have the critical documented protocol right now. So we will plan to develop a kind of the documented protocol for long-term COVID-19 patient right now. But some patients have anyway the fibrosis in their lung, but another patient complete resolution. And such patient exist, I think. So I don't know why some patients have complete resolution or some patients have fibrosis. And that's to be known later, I think. That's it.
Just from a pediatric perspective, I do run a post-ICU follow-up clinic, and we obviously seeing the survivors from the initial COVID wave coming through, predominantly from the MIS-C type of presentations that had been in the first wave. And I think given the fact that many of them have the admission profile of the first case that you had seen with severe multi-organ dysfunction syndrome, the recovery and resilience is always remarkable. In some ways, the children tend to do are looking the same as our septic patients who have multi-organ dysfunction syndrome that come back and look completely normal and very different from the patient who had been on paper in the ICU when you look at the notes in the follow-up. So I haven't been seeing any long-term COVID complications or long COVID cases. And there have been cases of some reinfections in the adults, but we are not seeing that in the children just yet.
Okay, thank you all. Dr. Singh, before I move off the slide, there was a question in the chat for you since you were just speaking. What's your experience been with vertical transmission of COVID-19 from mom to neonate?
The neonatal group of cases that we've been seeing and neonatal transmission has been really not in utero, but largely more contact related. The majority of the babies that have been admitted as neonates for COVID have been admitted as for investigation rather than positive COVID cases. I think also this also relates to the question of the pediatric surgical population, where we were doing screenings, COVID testing for pediatric surgical patients before they went into theater. And those patients also found a high incidence of COVID positivity, but not symptomatic from the COVID disease as well.
Interesting.
So the difference has been largely the surgical presentation and the COVID possibly being a commensal or a contaminant, if you would want to call it that, but not symptomatic in the sense that they are presenting from COVID disease.
Okay, I think the next few questions are just on anticoagulation. Are you using heparin sub-Q or enoxaparin sub-Q routinely in your COVID positive patients? I know we are, so.
Yes, I am.
So I think
regarding the same as with the non-COVID patients in the ICU. So we use the regular prophylaxis, and if we diagnose an event and trauma with non-COVID patients.
Yeah. Okay. And then are you using therapeutic or prophylactic doses of heparin or a D-dimer to guide your treatment?
It's a difficult question.
So we, after Active came out, we have now not done therapeutic anticoagulation on all critically ill patients. We're using the recommendation to do prophylactic for everybody, and then therapeutic if clinically we feel like the patient has developed a clot, whether that's a D-dimer elevation or an acute change in oxygenation or some other clinical indication. Then we'll put them on therapeutic anticoagulation.
So do I.
I agree.
At the Krebs.
Yeah.
Yeah, I think this issue for pediatrics is slightly different, as this has not been a standard of care treatment for non-COVID patients with sepsis and prolonged ventilation, prolonged ICU stay, unless they are older adolescents that can pre-expose to thrombosis. So this has been something that has been a new addition in the management of COVID patients, and because of our nervousness, the anticoagulation in the younger population, we've been opting to do heparin intravenously, just because the monitoring is easier, and also the control for bleeding would be easier with heparin, using the vitamin K and FFPs if we need to do so. And we've been trying to titrate it with the thromboelastograms rather than D-dimers, and sort of aim for normal to a little bit more anticoagulated on the TEGs. So that's been doing. Whether it's making any difference, I really can't tell. But in combination with that, these patients need quite routine cranial scans just to monitor any intracranial bleeding, particularly if they're younger and if they're ex-preterm babies that are within the first 3 months of life. So that has to be closely monitored. And we've had some GIT hemorrhaging with the use of heparin as well, especially when babies are not being fed. So that also complicates the matter. So if we are doing it, it requires a lot of monitoring in terms of the complications.
Yeah, definitely. Anticoagulation is not benign. So let me see if there were, I think that's all I had, but let me just go through the chat real quick. Oh no, here we go, one more. What about using heparin inhalation in COVID? Does anyone have any experience with that?
Personally, I don't.
I've never used it either.
Neither do I.
Yes, so do I.
And then I'll just touch on just 2 more questions from the chat, because I know we're way past our time, but I thank everybody for their attention. We seem to have some really good questions coming up. Someone wanted to know, angio-TC better for diagnosis of pulmonary thromboembolism? Question.
I think it's the best option in these patients because the angiography is too invasive for at least at the beginning, and the scintigraphy, considering that they have alveolar disease, will not be useful for these patients. So the CT is the best beginning, in my opinion.
Yeah, I agree with that. And then I'll just touch on just one more question that came up about clinic. Have you all had any experience with antifibrotic medication for progressive lung fibrosis in post-COVID patients in the clinic setting?
Right now, I'm thinking about how to use the antifibrotic agent right now.
Yeah, I think it's going to be an interesting study that comes up as we start to see more and more of these patients.
Yes.
Okay, well, it is 9:30, so I'm going to end the forum, but thank you all so much for all your expertise. It was really a wonderful forum to have you all. Thank you for taking time out of your very busy schedule to do this with us. So it was really wonderful. And please, for those of you all who are still in the chat, please fill out our survey. It is from the survey that we got lots of requests for international speakers. So here we are. So we do follow all those remarks that you put on there. So please fill it out. We're doing this for you. So give us some ideas about forums you'd like to do in the future. So
Thanks
thank you,
very much.
everybody.
Thank you very much.
No problem.
Thank you so much.
Good night.
Bye.
Thank you. Good night.
I have to go walk. Thank you.
Thank you, Dr. Cho.
See you someday.